Good morning, everyone. I welcome you all to the second part of the lecture of cardiac embryology by Dr. Tushar Gajjar sir. Those who have not seen the first part, I recommend you see the first part first. Sir has made the cardiac embryology very easy, and then come to this second part in which he extensively discusses the cause of most of the anomalies in the congenital cardiac surgery spectrum. So without further ado, I welcome Dr. Tushar Gajjar sir to continue the lecture.
Hello friends, welcome back to the cardiac embryology session 2. Today we are going to learn about anomalies. In last class of cardiac embryology, we saw the normal development of heart. Before we progress for the anomalies, let us recap the last session. So heart tube forms or the heart forms at the 3 to 4 weeks of embryonic life from the primitive heart tube. Initially, there are two endothelial tubes which joins in cephalate portion and remains separated in the caudal portion. This tube will develop some dilatation and constrictions. At the lower end or the caudal end, it is the venous end, that is sinus venosus, and the upper end or the cephalad end is the arterial end. This heart tube will go its first change, and that is called bulboventricular looping. The bulboventricular looping is nothing but a bulbar component of the primitive heart tube will come in front and to the right of primitive ventricle. This looping is called de-looping, and because of this de-looping, the straight primitive heart tube gets some shape like heart. The development of atria starts with sinus venosus and primitive atrium or primitive atrium. The sinus venosus component will form the systemic veins, and the primitive ventricle and the lung bud forms the pulmonary venous system. The sinus venosus component contains three tributaries: cardinal vein, umbilical vein, and vitelline vein. Two horns of sinus venosus are there in the heart tube. The left horn will regress and forms the coronary sinus. The right horn will form the systemic veins. The cardinal vein, right anterior cardinal vein, will form the superior vena cava. The right inferior cardinal vein will form the azygous system, and the umbilical and vitelline vein will form the suprahepatic portion of the IVC. Part of intrahepatic portion of IVC will be formed from in the liver, and that will be formed by the umbilical vein and the vitelline vein of either sinus of the sinus horns. The atria goes into the septation by fusion of the endocardial cushion at the AV canal, which divides the AV canal into right and left. A septum forms from the roof of the primitive atrium, which grows downwards, that is called septum primum, which doesn't fuse with the endocardial cushions and leaves a foramen, that is called foramen primum. Because of cell lysis, the foramen primum closes and new foramen opens in the upper part of the septum primum, that is called septum or ostium secundum. Another infolding develops from the roof of primitive atrium, which is called the septum secundum, and it doesn't fuse with the septum primum. It remains away from that, and it forms the limbus of fossa ovalis. Development of ventricle starts with the division of AV canal. From bulbous and the primitive ventricle to trabecular outpouching develops, and there will be a septum in between, that is called trabecular septum. The AV canal, which is divided into the right and left orifice, it is primarily related to the primitive ventricle. Now, something called right AV orifice has to transfer to the bulbus, because bulbus is going to form the future right ventricle. So this rightward shift will cause the shifting of the right AV orifice with the right atrium towards the bulbus. The only outlet for the left ventricle or the primitive ventricle is bulboventricular foramen. With this, there is a division of distal bulbus and truncus, formation of outflow tract by regression of the inner curvature of the heart, which leads to the left ventricle comes in the contact with the primitive ventricle comes in the contact with the posterior outflow tract. Then, with the progression, there is a closure of the embryonic interventricular communication, and there will be development of normal ventricular septum. Development outflow tract starts with the formation of semilunar valves at the level of bulbotruncal junction, endocardial cushions. There are 6 endocardial cushions which forms the semilunar valve. There is a division of distal bulbus and truncus by the lateral cushions into anterior and posterior outflow tract. The whole bulbotruncal septum or the conotruncal septum will form in a spiral form because of different locations of the endocardial cushions, and there is a transfer of outflow tract by regression of inner curvature of heart plus rotation at the conotruncal and conoventricular junction of counterclockwise of 110 degree, and the infundibular septum which goes and fuses with the trabecular septum or trabecular septum marginalis. This is how the outflow tract develops. This was the normal development which we saw in the last class. Today we are going to see about the anomalies. So let us see the anomalies of Atria. So how we saw the normal development? In the similar fashion, we will start the anomalies also in the similar steps like looping anomalies. So in looping anomalies, you know that this is called bulboventricular looping, where the bulbar component of the primitive heart tube comes in front and to the right of primitive ventricle. This is called de-looping, which we saw in the last class. So with this de-looping, the situs will be situs solitus, means there is a 3-lobe lung on the right side, there is a 2-lobe lung on the left side. The right bronchus is aparterial bronchus and the left bronchus is hyparterial bronchus. The right atrium receives the systemic veins, the left atrium receives the pulmonary veins, the liver is on the right side and stomach and spleen is on the left side. So this is called situs solidus. Now the anomaly occurs. Suppose during bulboventricular looping, the bulbus comes in front, but instead of going in towards the right side of the primitive ventricle, it goes towards the left side of the primitive ventricle. The stall development is same, so this will lead to the formation of called situs inversus, means it's a mirror image. The 3-lobe lung is on the left side, 2-lobe lung is on the right side. The left bronchus is aparterial, the right bronchus is hyparterial. The systemic venous veins receiving atria is on the left side and the pulmonary vein receiving atria is on the right side. Liver is on the left side and spleen and stomach is on the right side. Second anomaly of looping is the bulbar component comes in front but doesn't go right or left side. It remains in the center. This leads to an anomaly called situs ambiguous or mesocardia. This ambiguous might be like of right variety or the left variety. Right variety, right isomerism means there are 3-lobed both lungs, both bronchuses are aparterial bronchus, liver is in midline, and there is a malrotated gut. Both atria are of right variety. There is asplenia, while in the left isomerism there is a two lobe lungs on either side. Both bronchuses are hyparterial bronchus. Both atrial appendages are of left variety. Liver is midline. There is a polysplenia. So this is called situs ambiguous with either left isomerism or the right isomerism. Now moving to the venous anomaly. Let us see the systemic venous and pulmonary venous anomaly. We have seen that the superior vena cava develops from the right cardinal vein. There is a communicating vein that is called innominate vein, and there is a coronary sinus develops from the left horn of the sinus venosus. So we'll see the anomalies of SVC. So the coronary sinus in normal heart is like this, but suppose left common cardinal vein remains patent and it forms the LSVC which drains into the coronary sinus. There will be unroofed coronary sinus. The left superior vena cava or the left cardinal vein remains patent instead of becoming regressed, and it will have a opening on the LS side, or it opens itself in the roof of left atrium, or it will have a dual opening in the, or there is a totally unroofed coronary sinus, or the whole LSVC is draining into the coronary sinus, but there is an opening in the middle of the LSVC which drains into the left atrium. Another anomaly is the coronary sinus. The mouth of or the left sinus venosus wall will form the become atriatic, and the coronary sinus will be atriatic. The orifice is atriatic, but it has to drain somewhere. So either it will drain through the left cardinal vein into the innominate vein and into the RA, or the left cardinal vein is closed, then it will drain into the left atrium through the opening at the lower end. Sometimes the RSVC, instead of opening into the right atrium, it will open in the center, and there is opening in the interatrial septum that leads to the RSVC draining into LA. Or the right cardinal vein disappears and left cardinal vein remains open, which drains to the coronary sinus. So that is called absent RSVC. Let us see about the anomalies of inferior vena cava. The infrahepatic portion or the suprahepatic portion of the IVC is formed from the umbilical vein and the vitelline vein. But there is a interruption of the IVC. So IVC will drain through the azygous system or through the hemiazygous system into the SVC or into the LSVC into the heart. So this is called interrupted IVC. Interrupted IVC is nothing but the infrahepatic portion. Hepatic and infrahepatic portion is absent. That means there is a supracardinal and subcardinal vein, what we saw last time, is deficient here. So the IVC will drain, but it will drain through the azygous or hemiazygous vein. Sometimes the same like SVC, IVC will open in the center and it will get communicated to the left atrium. That is called IVC draining to LA. Sometimes there is a excessive development or the excessive development of the right sinus venosus wall that will lead to the formation of called Cotriatriatum dexter. It's a membrane between the superior and inferior vena cava and tricuspid wall. So that leads to the obstruction to the systemic venous drainage, and it will produce a condition called Cotriatriatum dexter. Let us see the malformation of pulmonary venous malformation. So we have seen that pulmonary veins forms from the splanchnic plexus from the lung buds and a venous outpouching from the posterior wall of left atrium. These two fuses and forms the pulmonary venous system. But suppose this communication gets interrupted. There is no communication developing in between this. So how the pulmonary veins are going to drain? You know that pulmonary veins are draining through the splanchnic plexus. This splanchnic plexus is having communication with left common cardinal vein, right common cardinal vein, and the umbilical vein. So in case of interruption of this fusion of primary pulmonary bud and the splanchnic plexus, it leads to either drainage of pulmonary veins into the left common cardinal vein, that is called vertical vein, and it drains into the innominate vein, or it will drain into the right common cardinal vein, means at the SVC or SVCRA junction, and the umbilical vein means into the IVC or portal vein. So it will lead to the formation of total anomalous pulmonary venous connection. Sometimes the left common cardinal vein, it drains, and this left common cardinal vein will go into the coronary sinus. So that will form the coronary sinus type of TAVC. This is another variety that is called Cotriatriatum Sinister. Mechanism is same. Instead of total interruption, there will be a membrane or the narrow opening of primary pulmonary venous chamber and the splanchnic plexus that leads to the formation of the syndrome or the condition called Cotriatriatum Sinister. There are plenty of classification, and there are varieties of Cotriatriatum Sinister. This mechanism is same like TAVC. It will drain dually either into the left atrium or through the opening into the interatrial septum into the right atrium, and also with the tributaries of splanchnic venous plexus like left vertical vein or the LSVC or the SVC, the right cardinal vein or the umbilical vein. So it will have a multiple drainage through various channels. Now, anomalies of atrial septation. So we know that this is the septum primum, division of the IV canal into two by endocardial cushion. Septum primum comes down and there is a gap remain there. Suppose lysis doesn't occur, then that opening is called septum primum or foramen primum, and it's called ostium primum ASD, along with the deficiency of the endocardial cushion, partial deficiency or partial fusion of the endocardial cushion. That is called septum or ostium primum atrial septal defect. There is a deficiency in the septum primum, leads to the formation of the secundum ASD or atrial septal defect. If sinus venosus wall regresses, then there will be a sinus venosus ASD between SVC or at the level of IVC. A coronary sinus of type of ASD develops if the left horn sinus venosus wall and the roof of coronary sinus is deficient. That will lead to the coronary sinus type of atrial septal defect. Let us see the anomalies of ventricular development. Now, before we go for the anomalies of ventricles, we'll first understand the concept of concordance and discordance or atrioventricular connections. When right atrium is connected with the right ventricle, that is called concordance. Left atrium gets connected with the left ventricle is called concordant connection. But if the right atrium is connected with the left ventricle or the left atrium is connected with the right ventricle, that is called discordant connection. So let us see the anomalies according to this. So we have first and foremost thing the connections, what we call the concordant and discordant connection. So if right atrium is connected with the right ventricle, left atrium is connected with the left ventricle, it is called concordant connection. The right atrium connected with the left ventricle, left atrium connected with the right ventricle, it is called discordant connection. There is something called like ambiguous. How we saw in the situs, there is ambiguous here also. Means the atrium is connected with right or left, both ventricle. Or there is a single wall. Double inlet means both atrias are connected with the same ventricle. Or there is a isolated absent connections, right or left. So let us see the AV cushion anomaly, or it is called AV canal defect. We have seen that there are anterior and posterior endocardial, ventral or dorsal endocardial cushion which grows towards each other and fuses with each other, divides the AV atrioventricular canal into two parts, right and left. There are other cushions also which develops from the lateral side and form the atrioventricular wall. Suppose there is a partial fusion of the endocardial cushion and there is a non-fusion of the septum primum with the endocardial cushion, leads to the ostium primum AST, or it is called partial AV canal defect, which leads to the partial fusion of the endocardial cushion also leads to the formation of cleft mitral valve, and there is a ostium primum AST. Suppose there is non-fusion of the endocardial cushion, it will lead to the complete AV canal, which means there is a single valve and there is a large inlet VST and there is ostium primum AST that forms the complete atrioventricular canal. So this portion is absent here. Now this is what is the normal heart. Here is ostium primum AST or partial AV canal, and this is complete AV canal. Rastelli has classified this atrioventricular canal on the basis of superior leaflet, right and left superior leaflet. If the right and left superior leaflets are equal size and the left superior leaflet doesn't cross the septum, it is called type A. But in type B, the right superior leaflet is smaller and the left superior leaflet is larger, which crosses and bridges over the septum, that is called type B. And in type C, there is no differentiation of right superior or left superior, it is a single leaflet, that is called C. Atrioventricular canal is also classified as a balanced and unbalanced. Balanced means each valve has to have it has to be having its own ventricle which is of adequate size, and if you see here, this is called the balanced AV canal, where both ventricles are of good size and both valves are committed to their individual ventricles. In unbalanced variety, one of these valves will be overriding the septum and one chamber will be larger and the other chamber will be on the smaller side. So majority of this valve will be having a overriding and committed to the one ventricle, that is called either right or the left variety. So if you see here in this picture, the right dominant unbalanced AV canal where the left ventricle is small. Here it is right ventricle small and left ventricle is dominant. Suppose these endocardial cushions, they don't develop, they remain atretic. They fuse with each other and they form atresia. So that leads to the formation of an anomaly called tricuspid or mitral atresia. These endocardial cushions also, along with the ventricular wall, will form the tricuspid or the mitral wall. During this formation of the delamination process of the wall, if that is in excessive form and In the septal area, it is in the regress form. It will lead to the anomaly called Epstein anomaly, where it's a defective formation of the septal tricuspid leaflet, which is shifted downwards towards the apex, which forms the Epstein anomaly. Similar way, it happens on the left side also. That will lead to the Epstein anomaly of the mitral valve. This is something called like crisscross heart. This happens after rotation of the ventricles after formation of the loop. That leads to the formation of the crisscross heart. Crisscross heart is nothing but they are either in the concordant, means right atrium is connected to right ventricle, left atrium is connected to left ventricle, but the ventricle will rotate after looping. This doesn't happen normally, and this leads to formation of a crisscross heart. Suppose connections are discordant, then there will be anticlockwise looping, and it leads to the formation of crisscross heart. So this is discordant connection, this is concordant connection. Mechanism is only rotation of ventricular after looping. Let us see about the discordant connection. We have seen the L looping, means instead of bulbar component coming in front and to the right in D looping, it will go into it come in front and goes towards the left side. That is called L looping. If it develops like in a normal way, it leads to the formation of dextrocardia, but something like this. If it forms like this, the right atrium is on this side, left atrium is on this side, and this sleeve moves towards this side, then it will form a mirror image or called the dextrocardia. But if the atrial development is like a normal development of atria, where the right atrium will develop on this side and the left atrium will develop on this side, then it will lead to the formation of called AV discordance. That means the right atrium will get committed to the primitive ventricle and the left atrium will get committed to the bulbus. So this portion will move towards this side and will lead to the discordant connection. Same thing happens if there is a D-looping also, where the discordant connection can come. Now here in discordant connection, the defects are all same of AV canal, the valve atresia, or the valve formation like Epstein and crisscross heart will be same like the concordant connection. Let us move on to the third anomaly of ventricle, that is called univentricular heart. Now univentricular hearts are, as we have seen, maybe because of non-formation of one valve, either right or left, so that is called single inlet, or there is no ventricular septum formation and both atria are draining into the same ventricle. That means it is double inlet. This also happens because of non-shifting of the or arrest in the rightward shift of the inlet portion of the primitive ventricle will lead to the double inlet ventricle. Or there is a single valve and single ventricle that leads to the common inlet. So we'll have in this single inlet variety a small trabecular pouch and a big ventricle, small trabecular pouch and a big ventricle, or we will have a indefinite ventricle or single ventricle. There is the anomaly of trabecular outpouching, which we saw. Like in this, it's like a normal heart. The normal heart will have an inlet portion, a trabecular portion, and outlet portion on either side. But if one of these portion will be primitive and will have only outlet portion, and it is both inlets are draining into one ventricle, This is called outlet type of trabecular or outlet type of pouching. Another variety is where it is not related to that, it is very small or tiny pouch, and outlet and inlet both are from the single chamber, and this is only a small pouch that is called trabeculated pouch or trabeculated variety of outpouching or the ventricle. This is on the right side and these are the left varieties. So let us see the anomalies of inlet transfer. We saw that this is the primitive heart tube which has had a looping, and the atria is divided by the atrial septation. The AV canal is divided into right atrial orifice and left atrial AV orifice. This portion of the right AV orifice beneath it has to move towards the bulbus, so the right atrium gets communicated with the right ventricle, future right ventricle from bulbus. If this mechanism doesn't occur, the shifting doesn't occur, that leads to double inlet left ventricle. You might be seeing that double inlet left ventricle is more and more common than the double inlet right ventricle. If this whole assembly moves towards this side, then it will lead to the double inlet right ventricle, which is a very rare phenomena. Second problem is the AV atresia and straddling. So this is called double inlet left ventricle, and if both orifices moves and the left ventricle is remaining very small, it is called double inlet right ventricle. Non-formation or the atresia of the right valve, or it is called tricuspid atresia, leads to the formation of called tricuspid atresia with single ventricle, and right ventricle is rudimentary. Similar way, if the left AV valve is atretic, leads to the formation of a syndrome called hypoplastic left heart syndrome. Means there is atretic mitral valve, there is a smallish ascending aorta and arch, and this leads to the phenomena called mitral atresia. So we have seen the univentricular correction because of non-shifting of the inlet portion leads to double inlet left or double inlet right ventricle. There is another phenomena which is called the atretic mitral valve or atretic tricuspid valve, leads to the formation of single ventricle tricuspid atresia, mitral atresia, hypoplastic left heart syndrome. There is another variety where there is a functional single ventricle where it is unbalanced AV canal, or there is a single no large VSD will lead to the again a functional single ventricle and univentricular heart. We will see the another anomaly which is called overriding. Normally, if the ventricle will have its own valve here as well as here, that is called without overriding. But any portion of any one valve overrides the ventricle, it is called overriding. If it is less than 50%, it is called overriding, and here if you see it is overriding, but here if you see it is more than 50%, it will lead to the double inlet variety, and here it is, if you see, it's completely overriding. There is another anomaly called straddling. Straddling is nothing but the chordae of one particular valve will either attach to the crest of the ventricular septum, or it will go and attach to the opposite side of the ventricular septum in type B, or it will attach on the opposite wall of the opposite ventricle, will lead to the straddling of type C. Now these all variety will have a complex anomaly. The ventricular septum develops by inlet, trabecular and outlet portion, and there is a called membranous septum. Any anomaly or defect on fusion of this area will lead to either membranous, perimembranous, subaortic, subpulmonic variety of or inlet variety of ventricular septal defect. Defect in the trabecular portion is called muscular ventricular septal defect. We would like to mention about the Garbody defect. It is nothing but it is in the AV septum. If you see here, the tricuspid wall is slightly towards the apex and the mitral wall is slightly on the higher side. The septum in between is called atrioventricular septum. And if this septum is deficient, it will lead to the formation of defect that is called Garbody defect, means left ventricle to RA shunt. So this defect is called Garbody's defect. It will be of either direct variety or it will go through the VSD and perforate through the tricuspid wall. Septal leaflet of tricuspid wall will lead to the type 2 of Garbody defect. Excessive growth of trabecular septomarginalis will lead to the formation of the anomaly called double chambered right ventricle. That will be secondary due to fibrosis of the mid cavitary fibrosis leads to the formation of double chambered right ventricle. Let us move on to the maldevelopment of ventricular outflow tract. Normal development of ventricular outflow tract occurs because of multiple mechanisms like transfer of outflow tract, counterclockwise rotations, transfer of infundibular septum, and plugging of aorticopulmonary septum. There are two more things like secondary heart field and cardiac neural crest. They help in this formation of ventricular outflow tract. The second heart field will help in formation of growth and rotation of the outflow tract, while cardiac neural crest help in development of aortopulmonary septum. So we have seen this conal regression, subaortic conus regression, and regression of the inner curvature of heart, and plugging of infundibular septum into the between the trabecular septum, two limbs of trabecular septum marginalis. This all will lead to the formation of ventricular outflow tract. Now we'll see during embryonic life, in straight heart tube we have divided the outflow tract into the anterior and posterior outflow tract. So this is the anterior and posterior outflow tract. During delooping, it will get delooped and it will have a counterclockwise looping if you are seeing from down below up from apex. So if you see, this is the first counterclockwise loop which leads to the formation of side by side aorta and pulmonary artery. Further counterclockwise rotation will cause aorta right and posterior and pulmonary artery left and anterior, and subpulmonic conus will remain, subaortic conus will disappear. This will lead to the formation of normal heart in situs solidus and delooping. Suppose the subaortic conus persists and there is a clockwise looping. This is counterclockwise loop, this is clockwise loop, which lead to the formation of called anomaly transposition of great artery. Now if we see that instead of D looping there is a L looping, the rotation will be in a counterclockwise way and the clockwise way, and the aorta will come on the left side, PA will be on the right side, and further clockwise rotation will lead to the formation of this normal, inverted normal, that is called aorta is left and posterior and PA is right and anterior, but this is in a inverted heart or the dextrocardic heart with the normal heart. But there is a counterclockwise loop, subaortic conus is patent, then this will lead to the formation of anomaly called corrected transposition. So pulmonary artery is on the right and posterior, while aorta is on the left and anterior. So before we go for the anomalies of the ventricular arterial outflow tract, let us see about the certain terminologies. So there are two things in ventricular outflow tract, that is connections and relations. So in connections, if you see there is a concordant connection, means The right ventricle is connected with the pulmonary artery and the left ventricle is connected with the aorta. That is called concordant connection. While the discordant connections are the aorta is connected with the right ventricle and pulmonary artery is connected with the left ventricle. There are double outlet right ventricle or double outlet left ventricle, or there will be a single outlet, either pulmonary atresia, aortic atresia, or there is a persistent truncus arteriosus. So we will see all these connections in detail. Along with connection, that is called relationship. In a normal dextrocardic heart, the PA is left and anterior, aorta is right and posterior. While in inverted heart, the PA is right and anterior and aorta is left and posterior. Suppose there is a D malposition. In that, the aorta is right and anterior, PA is left and posterior. While in levomalpost great arteries, aorta is left and anterior, PA is right and posterior. In anterior malpost, both are anteroposterior. So in maldevelopment of ventricular outflow tract, either there is a normal connection and normal relation, normal connection and abnormal relation, or abnormal connection and abnormal relation. So outflow tract anomaly occurs because of failure of transfer, lack of rotation of distal bulbous and loopy, lack of transfer of infundibular septum, and there will be a faulty plugging. So as earlier we said that these two areas like central CNC as well as secondary heart field will help in formation of outflow tract. Any defect in this will lead to the various kind of anomalies of rotation or septation. So in normal heart we have seen that aorta is right and posterior, pulmonary artery is left and anterior. In abnormal positions like there is side by side in DORV, aorta comes anterior, PA goes posterior in transposition, and there will be a non-septation. It is called truncus arteriosus. So this is the classification suggested for the congenital anomaly of the ventricular outflow tract, where secondary heart field, neural crest cells, myocardium and endocardium, any abnormal things will lead to the formation of various congenital anomalies of outflow tract. Let us understand the defect in this simplified diagram which we have seen earlier. In straight heart tube wise side, the pulmonary artery is like this, aorta is in the anterior position. This is the lowermost. So first counterclockwise loop in D looping and clockwise looping in L looping leads to the side-by-side relationship. Here aorta is on the right side, PA is on the left side. And on the L loop side, PA is on the right side and aorta is on the left side. So if there is a second counterclockwise looping occurs, it will lead to the formation of normal heart, where aorta goes posterior, PA goes anterior and to the left. If there is a clockwise looping, it will lead to the formation of TGA. Similar way, here counterclockwise looping leads to formation of anomaly called LTGA or corrected transposition, or clockwise looping will lead to the normal dextrocardia. Similar thing here, counterclockwise rotation for normal heart. Here you see the conuses are there. So subaortic conus disappears and there will be a counterclockwise looping. It will lead to the normal development of heart. Heart is a normal heart. But the subaortic conus persists, subpulmonic conus disappears, and there is a clockwise rotation leads to formation of TEA. Same thing in this picture, what we explained earlier, the embryonic heart tube straight, first rotation counterclockwise, side by side relationship, and then further counterclockwise normal heart or clockwise rotation will lead to the formation of dextro malposition of great artery or DTGA. So, conotruncal embryologically anomalies are truncus arteriosus, tetralogy of Fallot, DORV, DOLV, transposition of great artery, conoventricular septal defects, and interrupted aortic arch. So, first we'll see the truncus arteriosus due to failure of aortopulmonary septum or septation, which leads to the common trunk, and it will lead to the formation of the anomaly called truncus arteriosus. If the infundibular septum moves leftward, superior and anteriorly and fuses with the free wall, it will lead to the formation of tetralogy of Fallot. Because of this faulty plugging of the infundibular septum, instead of it is falling between the two limbs of trabecular septum marginalis, it will go and fuses with the anterior limb of trabecular septum marginalis, and a malaligned large ventricular septal defect will form. This will lead to the other sequelae of overriding of aorta, pulmonary stenosis, and right ventricular hypertrophy. In embryonic life, there are two conuses, subaortic as well as subpulmonary conus. Normally, the subaortic conus disappears, and wherever the conus persists, that artery is pushed forward. Means pulmonary artery is coming forward, and the sub aorta is going posterior. But if the both conuses persist, so inner curvature doesn't regress. So both the arteries are in relation coming anteriorly and in coming in the relation with the right ventricle. So this will lead to the formation of double outlet right ventricle. Along with that, the rotation also doesn't occur, and because of that, these two arteries will have a side-by-side relationship. Or they will have a partial rotation, then it will have a normal relation, but both arteries are arising from right ventricle. Suppose the both conuses disappears, then both the arteries will be pushed posteriorly and they will come in contact with the posterior ventricle, that is left ventricle, will lead to the formation of anomaly called double outlet left ventricle. Again, same like double inlet left ventricle, double outlet left ventricle is rare. Regression of both coni are very rare. So we'll see the double outlet left ventricle rarely than the double outlet right ventricle. Transposition of great artery forms because of absence of conoventricular rotation. So it will rotate either the clockwise rotation and persistent of subaortic conus. These two things will lead to the formation of transposition of great artery. Means aorta will be committed to the right ventricle and the pulmonary artery will be committed to the left ventricle. The conal septum, it is malaligned, then it will lead to the formation of subpulmonary or the conoventricular variety of the VSD or the subpulmonic VSD. So this is an anomaly of conus. What we are seeing here, the subpulmonic conus is patent in the first picture. That means subaortic conus has disappeared, subpulmonic conus is present, and this is the normal heart. Here, subpulmonic conus has disappeared and subaortic conus is present. This will lead to the formation of transposition of great artery, Here, both conuses are present, which leads to the formation of double outlet right ventricle. And here, both conuses are disappeared, so this will lead to the formation of double outlet left ventricle. So normal heart, transposition of great artery, double outlet right ventricle, double outlet left ventricle. So in this slide, we are seeing that there is a normal septation which leads to the normal heart with a spiral septum. Unequal division of the septum of aortopulmonary septum will lead to the formation of tetralogy of Fallot with pulmonary atresia, or if it is on the right side, it will lead to aortic atresia. There is no spiraling, straight septum will lead to the transposition of great artery. There is a defect in spiral septum, leads to the aortopulmonary window. Non-formation of the aortopulmonary septum will lead to the truncus arteriosus, and malposition of spiral septum will lead to the formation of hemitruncus. So we have covered the anomalies of heart. In the third session, we will do the developmental anatomy of aortic arch and its anomaly.